sketch actually is. It's an endemic disease, and we know about it here, way up here, but it's actually a Western Hemisphere disease, so it actually occurs in many other parts of the North America, South America, Central America. It doesn't show that, but there are pockets in Central America. Actually, the first case of valley fever, coccidioidomycosis, occurred in Argentina over a century ago, 1893. The other point I wanted to make with this slide, though, is that pretty much most of those areas that are in yellow are pretty rural areas. And if we blow it up to a more focused area in northern Mexico or Mexican and the Southwest here, it's actually true pretty much for most of that area as well, except, of course, kind of where we live. And this is, I like this slide very much as an Arizonan's view of the United States. If you sort of see the overemphasis about our state here. But for this disease, I think it's really quite appropriate because 2/3 of all U.S. infections of valley fever occur in Arizona. 2 out of 3 in Arizona. So, in fact, most of that occurs in the 3 counties of Pima, Pinal, and Maricopa County. So you can think of that really as the valley fever border for the United States. We live there. So this is looking up at the Catalinas, and in some parts of the dirt around us, the arthrochonidia, or the spore of the fungus Coccidioides, shown here by a scanning EM. This is a single spore. It's about the same size as Mycobacterium tuberculosis, 3 to 5 microns. It's a very nice size if you inhale it to go all the way deep into your lungs and not to get exhaled. So it's a very good delivery device for infection. And if you get infected, you will develop, by definition, a respiratory tract infection or a pneumonia. This is somebody who has a pretty striking pneumonia. And you can't tell that really from any other kind of pneumonia. Ken Knox will be discussing that, I'm sure, in part of his remarks. And if you actually looked at parts of that lung under a microscope, you'd see this. This is very different from this. This is a spherule. It's instead of 3 to 5 microns, it's now grown to be 30 to 70 microns. It's still very, very small, microscopic. Have to look under a microscope to see it. But inside, there's literally 100 or more progeny called endospores. And when this thing pops every 4 days, is about its cell cycle length, you release 2 log amplification of the original spore that caused the infection. So just in overall numbers, what we see as an impact here in Arizona is there's roughly 100,000 infections per year. That varies, and Heidi's going to talk to us about that quite a bit in the first presentation. Not all of those infections develop an illness. Probably about 1/3 actually seek medical attention because they have a pneumonia or some other syndrome caused by this infection. And a subset of those that seek medical attention actually get diagnosed. A lot of them don't get diagnosed because the doctor doesn't think to do that, or because the diagnostic tests are unsatisfactory. But then some do get diagnosed, and then of that, a smaller number still, we think roughly 400 a year, develop this infection not just staying in the lungs, but going all around the body to other parts, brain, bones, skin. We call that disseminated infection. And an even smaller number actually die of this. It can cause death, but it's of the 100,000 per year that get infected, maybe 1/10 of 1% of that go on to actually die of this infection. So those are kind of the numbers, and this is considered pretty much the mild form of the disease, but diagnosed disease, we now know from Arizona Department of Health Services data that it's anything but mild. 75% of workers lost, stopped working, and half of them lost greater than 2 weeks. Illness lasted in general more than 6 months for half of the patients, and 40% were hospitalized. And recent data I just saw come out this week for 2012 indicated that hospital costs are now up to $100 million a year. And there's another publication from California that says that their hospital costs per year are a couple of $100 million a year. So between the two states alone, you have in hospital costs $0.3 billion per year. That doesn't take into account time lost work or outpatient care, which is also quite considerable. So there really is quite a financial burden. And then this much smaller number has major morbidity and consequences. So these are just pictures of people with extrapulmonary spread. These are abscesses on a fellow's back that were really fluctuating, just like Staph aureus bacterial infection when they drained, but they were caused by this fungus. And here, this is an image of the spine of a person who has, this is the normal part, this is the spinal cord. You want to have one of those, but this little thing here is an abscess. These are all abscesses. This was actually a continuous anterior cervical abscess from the cervical vertebral column all the way down the mid-chest. So these are very complicated infections, get very multidisciplinary, and those patients can be very sick for very long periods of time. This is actually what's going on with cases reported. This was a high of 16,000 cases reported in 2011. But what I don't think people have really seen covered in the news have been that it's come down in 2012. And although we haven't finished 2013 yet, estimates look like it's come down to roughly 8,000 from 16. So we've half the number of cases in the last 2 years, which begs the question, really, what could be causing these kinds of changes? You know, they go up and they go down. What is it? And we're going to actually start with that question in mind. Heidi Brown is a climatologist in the College of Public Health. And she's going to address actually some very significant influences of weather on the year-to-year changes in valley fever case rates. Second, we'll talk with Ken Knox, who's here with me, to talk about pulmonary toxicotomycosis, a lung doctor's perspective. The announcements had, it was a blood doctor, I think it was, but we got the correction in. He's a pulmonary physician, he's head of the Division of Pulmonary here at University Medical Center at University of Arizona. And then we'll have a break. After each of these speakers, we'll have time for questions. And I suspect that probably they won't be staying for the whole rest of the time, because at the end we'll have a roundup period of time for questions as well, but that probably will be mostly for the third, fourth speakers. And those will be my good friend Lisa Shubitz, veterinarian, will talk about the pet connection, valley fever in animals, and finally I have some other thoughts I'd like to bring to you as the final discussion for the afternoon. In addition to all of us here, we're also delighted to have join us Congressman David Schweikert, who is co-chair of the newly formed Congressional Task Force on Valley Fever, along with Kevin McCarthy, the congressman from Bakersfield, or the Bakersfield area. And I'm delighted that Congressman Schweikert can join us today. He and Congressman McCarthy are bringing increasing visibility in the federal arena to this disease, and I think it's very appropriate, and thank you for your time. I'm sure either at the break you'll have time to ask some questions, or perhaps later on in the afternoon as we go through it, as well as for the people that are doing the presentations. So let me end then, and Heidi, why don't you come up and we'll see if we can find you on this desktop here. Always say that. Here's your driver, and I'll give you this mic right now. You want this? Yeah.
Am I projecting? Back back of the row, am I projecting? Okay, thanks. All right, so thanks for that introduction. I'm really glad to see everybody here. There's a fairly good chance I'm going to trip over this cord because I walk around a bit. I'm Heidi. I'm right across the street, right across the way here. I'm in the College of Public Health. I'm actually a vector-borne disease epidemiologist. And what in particular I look at is disease patterns, where they're occurring and why they're occurring and when are they coming out. So I'm really interested in seasonality. And as a result of that, climate becomes a huge issue for me because it usually dictates when mosquitoes are coming out, why they are where they are. John and I probably should have coordinated our slides. I think there's at least one picture that we both have the same one of. But that issue of where the disease is occurring becomes a really important one for me. So we have a little bit of overlap of the distribution, but I'll make the argument that weather has a big part of why that is where it is. Just to make sure I don't have any slides with anything on there that I haven't explained to you. And I'm fairly decent on being interrupted with questions, so if you want, don't get lost because I've said something too quickly, just stop me and I'll rewind for you. But what we're looking across the bottom is we're looking at this fungus and how it's growing and walking across from the immature phase and as it dries out in the spores, which we already got a nice little brief overview of. That's the good one. There we go. All right, so just briefly where I'm going to go, the when is going to be the slides you've seen at least one of already, but we're going to talk a little bit about where it is and why it is where it is. And specifically this notion of the lower Sonoran life zone, which I like, and that's us. We own it whether we want it or not, right? We'll talk about when, that's seasonality, when the disease is occurring, when we see cases, and try to get into some of the whys about why that is. I'll talk about the grow and blow hypothesis that you might have heard. And then as an epidemiologist, we always talk about who are the susceptible individuals and how that also affects where we're seeing it, when we're seeing it, and these kind of factors. And then to keep my questions on, I did the so what, which is, what are we going to do with this information? Which is, we have a lot of information, and I'm unfortunately not going to give you as many answers as you want me to, but I'm going to give you some good food for thought and sort of issues of where we'd like to go with it. And that's what my so what is. So this is where we're going today. So that's my one. It's almost the identical of your red one, so sorry about that. But we're gonna zoom in and talk about it. So as was already mentioned,
I'm glad you didn't show all sorts of spots that I didn't on that.
Yeah, I know, it's a really consistent map, right? Notice that his was actually from, I think, 2005, 2006. This one's from 1970. So we haven't, it's still where it was. The color, we added color is pretty much the only difference between our two maps. But again, it's our disease. We own it in North Central South Americas. It's named from the San Joaquin Valley, where it was first sort of identified and recognized of what we're talking about and grouped together. Usually rural. We already got just like Tucson and Maricopa. Yeah, not so much. But it's usually thought of as a more rural disease. But that just kind of brings us into where we're looking at it. All right, zooming in, almost this identical map, also very similar, but kind of looking at it. Whether we want to or not, we own this disease, especially here in Arizona. We have about 66% of the cases, based on CDC reports. This lower Sonoran life zone was first kind of brought up in the late 50s, which is trying to understand where this disease is and why it is in the places that it is. And what it seemed to be is you could find an association with the soil type. So we're talking about a soil-growing fungus, so that kind of makes sense. And the soils that are associated with this lower Sonoran life zone tend to be associated with this fungus. However, that's a narrower definition than it needs to be, as you've seen. It's moving out into areas that are beyond our saguaro cactus and moving. But it's a kind of so at least a starting place. And it is found in some of the semi-arid places as we're going along. So that's kind of, getting us into this, what's driving it. So we're looking at soil types that are driving it, and we're also getting into this semi-arid. There's something on the weather that's having an influence of what's going on and where the disease is. All right, so zooming in a little bit further, we're actually looking at cattle here, but the human, for better or for worse, we look a lot like cows. This is, sometimes, right? So this is looking at 5 to 6 year old cattle and looking at, long enough out there exposing themselves. It seemed to be really related to what we were seeing in humans that had been in the area for at least 12 years. So what we're looking at, and I kind of put that in is because the first map, it was kind of all of Arizona, right? And then we're still kind of most of Arizona, and now you're starting to get into this, well, there's still pockets, right? So the gray areas is sort of where it's kind of estimated that this pathogen is growing, and we're getting some pockets of where it's not growing as well. And it doesn't, which is what we want to hear, like, why is it not growing in these places, but it's not growing, and what is it about those areas? And so this is when the distribution of the where starts to get into that climate pieces of when and what's going on. So it seems to be areas where we have this sterilizing heat, where we're getting enough heat that's knocking back a lot of the competitors for this fungus, so that it's kind of the only one out there growing in the soil. We're looking at areas that are hot and dry. If you're familiar with Tucson, we've got a lot of hot and dry. You're familiar with the disease. We have this association of when it kind of dries it out, and then the spores get blown and it starts moving around. So that sterilizing heat to dry out the fungus so that we get these spores that can then be aerosolized, but also that it's having this effect where it's reducing the competitors for this fungus. And then we need some rain. We need some rain so that this fungus can grow and proliferate and get out and do what it wants to do. So we have rain, and then we need that wind. We need that wind in there that picks it up and blows it, unfortunately, up our noses and into our lungs. And so those are kind of the three things that we're thinking about. It's got to be something about this area that's going to be hot. It's going to be something about these areas where you get the rain. The question that you're hopefully all asking is, well, how much rain do you need, and when does that rain fall? I'm not going to answer that because I don't know. Wish we did. But that kind of having rain at the right time, having this cycle of where you're getting heating, drying it out, wetting it, letting it grow, getting it so that it aerosolizes and blows. These are all factors that we need in these areas where we're going to find this disease. All right, so that's kind of our that's kind of our where area, giving us an idea of where this disease is happening. Let's talk a little bit about when. I like this slide. It's stolen from the 1950s. Again, another side note that's fascinating about this disease, when you're looking into the wheres of this disease and that climate thing, there's a lot of research that was done on it in the late 40s, 50s, and 60s. And then we kind of have this pause, and then there's been a rebirth in recent years where we're really trying to get a good handle of what's going on with the disease in terms of these factors. The medical literature is consistent all the way across, where they're always trying to figure out what's going on inside the patients, which is, for me, an interesting kind of thing. But what we're looking at here is we're getting a pointer. I probably pushed a button I wasn't supposed to. Sorry about that. All right, I'm going to walk over to it because I'm going to lose it again. Anyway, so up in the top you can read the words. So first we're talking again about that sun. We're having that area, maximum summer, where it's really drying out, and drying out the area and growing it. I want you to notice two things: rodent hole and creosote bush. We had some in the picture that you had. There seems to be an association when we're trying to look at that microclimate, that micro area of where it's happening. Seems to be an association with rodent holes and with creosote. It's kind of the strength of that. We'll talk a bit more. It's a difficult pathogen to find when it's out there. We get the rainy season, June, July, August. That's when we start getting this proliferation. We're getting the growth of the fungus. And then we get into this dust storms and wind, sort of like right now, right? We keep getting these dust warnings when you're driving down the highway. So that's when it's pulling out and blowing it up. What we see here, again, this is from the 50s, 60s. We're looking, there was a lot of issue with ag. So people going out in the fields, actively involved in, close to the dirt, in addition to these times when it's blowing, is your susceptible individuals getting them exposed. And then we get our incubation period, and then we start having our cases later in the winter. Okay? Just kind of walking through it. There we go. Seasonality. Another piece about this disease, which is challenging and interesting, is depending upon where you are, you get a different picture in terms of the seasonality. But what we're kind of looking at here, this is CDC data, looking at from 98 through to only 2001, but kind of seeing this winter season that we're seeing a little bit more of this kind of driving it. It flows from what we were just looking at, that we've gone through our cycle and we get these diseases happening a little bit later. All right. Hopefully not over on time. Still trying to get back to this So the precipitation is helping us with this grow phase, and then we're getting into the blow phase. So this slide is very similar to the previous one in terms of the words that are on there. I'm not tall enough for it, but me and technology. Here we go, that's a light and there's a cleaner. All right, so we have the fungus in the soil. We're getting high temperatures, low precipitation, sterilizing it, knocking out the competitors. Okay, and then we get increased soil moisture and it starts to grow. Its competitors aren't out there. Fungus gets to kind of freely grow in the area. Then we have our drying out period, spore formation, and then we start getting into our blow period, where it's been dried out, it was happily growing with no competitors, it's drying out now, and we get the wind picking up, and it gets dispersed, inhaled, and that's when we start seeing our cases happen. All right, so a little bit of data behind it, a little bit of what's it. So again, it's sort of the third slide, but we're kind of thinking about it in a slightly different way here. What we're looking at is, if we have for this grow period, so when does the precipitation fall? Remember I told you to have that question, you're asking me how much precipitation and when does it need to come, right? So we have to have some sort of in this grow period, if we have a wet grow period, then the fungus gets to proliferate, and then we have this sort of lag before we start seeing our cases, where all that other stuff has to happen, right? So we get the fungus out there growing in the area, and then we have a lag. So it's by month. So if I have a wet October, November, December, I'm going to expect to see more cases in the following winter season. And if I have a dry one, I'm going to expect to see fewer cases. All right? And then with the blow is happening sort of much more because of the incubation period. The blow is happening much closer to the time when the patients are starting to appear. So if I have a wet period when this blow period is happening, I'm actually going to have a reduction in my cases, right? Because it helps to wash it out of the air, or it's not getting that dry out period and it's not blowing around. If I have a dry for that season, that later season, that's when I see my cases. All right? Okay. So what this is some of the work that was done by Andrew Conray and one of his graduate students, looking specifically at that. They use data from both Piedmont and Maricopa County, and what they're looking at is they're finding an association between precipitation and when that precipitation is occurring and what that's doing to cases. So we're looking here is in that early October, November, December rain period, if we're having a lot of precipitation here. So this is increasing amount of precipitation, and what we're looking at is exposures. We're looking at the population that we're seeing coming down with cases. And you see a faint line. What we're looking at is if I have low rain during that previous year's precipitation, October, November, December, I see fewer cases. And if I have a really wet previous year's winter rains, if I have a previous, I'm seeing more cases, right? And then during that blow period, what we're looking at here is you see the line that we're going in the opposite direction. So if I have high precipitation in that period where those exposures are happening, where the cases are starting to occur, I'm kind of having that, when I should be blowing, I'm kind of rinsing it out. And I end up with fewer cases, as opposed to if I have low precipitation during that blow period, I have higher cases. All right? So it's a little bit confusing because we have a lag. We have a lag of when that precipitation is happening, that it boosts the cases, and when it happens that it reduces the cases. And that lag is a really good question that I'd love to be able to answer. And that's where we get a little bit into the susceptible individuals and what they're doing, because we humans tend to mess up these systems in terms of trying to have a clean signal, especially when you're dealing with these kind of pathogens. This is my dog helping me dig in my garden. You can't see either one of us. Yes, you guys know enough to know what that means. Where I am wearing a mask. My tomatoes did really well, thanks. But you can see this, and you'll see this in the literature, where their dogs get exposed because they went out, they went hunting, they're digging in rodent burrows. Again, this idea of rodent burrows is kind of coming up, that whether or not that's sort of a micro area of where something's happening. And you'll see cases happening with that. You'll also see I put a couple of cases in the 50s again, and then also more recently, people out there and exposing themselves in different ways to the pathogen. It's going to have a different effect on what we're seeing in terms, certainly in terms of the seasonality of the disease. But it's some of the ways that we expose ourselves to this disease in addition.
Quick question.
Sure.
Being that you talked about a mask.
I'm sorry?
Being that you mentioned mask.
Yeah, I put the mask mostly because of the dust.
Right, but being that it's so small, how effective are masks?
I'll leave this to the physicians. My guess is that probably at this, I mean, I don't know that are we going to advocate? I'll let the physician answer.
Okay.
For me, the mask was mostly because of look at the dust. It was pretty horrible. The dog didn't have one. But yeah, the dog didn't, but we'll let the physicians answer on that one. All right, so can we get to the so what, right? So you have lots of hopefully pieces of information that are probably sparking more questions. Sorry that I'm giving you answers, but at least it's pieces. And we'll talk about the so what. I like these two quotes. I'll give you a little bit of time to kind of have a look at them. This is from the 70s, and the picture unfortunately hasn't changed very much today. But this is kind of getting to that idea of what I was talking about is there's a lot we still don't know about this, the fungus in the soil, where it is. You know, is my backyard an exploder? Do I have to be exceptionally concerned about it? Or am I in one of those white spots? You know, and why are those white spots where they are on that map we flew before, where we were looking at the cattle? Why are those white spots occurring where they are and what's driving it? And it's really difficult. Wouldn't it be nice to just go out and say, this is an area that has the pathogen and I'm going to treat here? It's really hard to grow this pathogen in the lab, let alone to try to figure out in a state like Arizona where it is and where it is, you know, why it is where in those specific areas. All right. And this is sort of driving home that, I guess I like old literature because most of my slides are really old, but I find it fascinating. But this is somebody's backyard. And there was 10 kids that ended up dying of the disease, and they went in to try to figure out, well, where did these exposures happen? And what we're looking at here, with great trepidation about my pointer, this is a positive, and these are negatives. All the minuses are negatives. So, you know, yes, no, in just in the backyard, you know, when you're looking at that kind of, like, how do we figure out exactly where this pathogen is and try to be able to answer it? And then, you know, if that's one person's backyard, blow that up to the state of Arizona and throw in California for good measure. And again, I told you I'd give you more questions than I would answers. But why? Right, because here's my positive spin, because I want to end on a positive note. What are we going to do if we can find some way of doing that? My job as an epidemiologist, what I like to do is figure out when are you at greatest risk? Is this going to be the year that's a bad year, or is this going to be the year that's a good year? You know, are we going to have fewer cases this year? Where? Which part of my backyard? Which part of your backyard? Is it your yard or is it your yard? You know, which areas are we looking at? Is there a way to get a better idea of what's going on in those areas? And then you use these to inform public health. You know, could we get to the point of having an air quality index, Cocci? You know, like, this is a bad day, this is the day that we don't want to be out there. And if we could get to the point of treating specific areas. That's sort of our so what. And I'm going to stop there, hopefully not too much over in my time.
Thank you, Heidi. So I think we'll have time for a few questions at this point, if anyone does. Yes, ma'am.
You're saying that there seems to be some sort of relationship potentially with rodent holes in the bushes. If we were to eliminate those around our homes, would that potentially help?
That's a really good question.
Because I'm out in a rural area, and my animals are dying of valley fever right and left. So I'm just wondering if we clear it more,
Right.
or because we have more open land, will that create more dust and cause another problem?
Sorry. Yeah, that's a really good, so the literature, what you'll see in terms of the rodent holes is often when you're looking at the dog infections, people tend to, like, it went in and it was digging in some of these rodent holes. If when people go out and collect samples and they're doing the samples, it tends to be that they'll find more positive samples. Like, if I go out and, you know, check a whole area, my positive samples tend to be closer to these rodent holes. Or it's also been associated with the creosote bush in terms of what kind of other competitors are being knocked out. I think it's going to be a question of getting the right rodents and which ones. That association is at least something that we can sort of hang our hat on. I don't know if that's your total answer. I, as a dog owner, I don't know which animals you have, but as a dog owner, I'm really cautious about, like, well, mine can't go off leash because they run away. I think that trying to control them, not to let them exposing themselves to rodent holes would certainly be something I think actively trying to do.
We'll have some comments from Lisa Shubitz.
Yeah, she'll be great.
We'll come
Wait
back to
until
that
the
question.
afternoon for the animal ones, actually.
Heidi, can I just ask, so how much of the year-to-year variation that I was showing going on do you think this model, the rainfall and its impact has on that year-to-year variation?
It seems that based on the models that it's actually a pretty good fit in terms of
Good meaning 20%, 40%, 80%?
So talking statistics, 80% of the variance in Maricopa was explained by it. Trying to translate that statistics into something that we understand better than numbers like that. It seems to the Maricopa model fit better than the Pima model did, but both of them were pretty good in terms of explaining it. So if I looked at the previous year's winter's precipitation and the concurrent year's lack thereof, I did a pretty good job of being able to predict.
Other questions? Yes, ma'am.
Based on the weather this fall, what do you predict for next year?
I can't answer that without looking at a model of really getting the data. I haven't been in Tucson long enough. I'm only a recent local to know whether or not this was a wet year or a dry year. Thanks. To know whether or not this was a wet year or a dry year. And we haven't, because of the unfortunate thing about our model, to be quite honest, is I need the concurrent, right? So I need to know what's happening right now to be able to predict what's happening right now. But at least you should be able to get to the point of saying last year, previous year was more wet, less wet, and therefore if this year is wet, then X will happen. But I don't know Tucson's weather well enough to be able to compare off the cuff on that.
Other questions?
Sorry for ski year.
Are you indicating that the winter rains are far more important than the summer rains we have here as far as the growth rate and the subsequent infections?
So at least in this model, with the way that it's working, we are looking at December, October, November rains in terms of how they're predicting. I assume that you're asking on account of the monsoons, because usually we tend to think of it where the monsoons are giving that really nice wetting and pulling out and giving it. This model, the way that it ended up working, and it predicted pretty well. It seems to be more linked to that previous winter rains and what they were having based on when you're looking at exposure seasons.
Question back.
Did you do any studies with the soil pH?
I don't in particular. Unfortunately, I'm an epidemiologist, so I look at the people and when the people are happening. There's quite a few groups that do look at the soil. It's just, it's kind of a needle in a haystack factor in terms of trying to go out and say, yes, in this soil with this pH. There have been, again, going back to that nice old literature, there are some really old studies that took it into the laboratory and looked at things like humidity and temperature and pH and trying to find that sort of an association with it. I think it's still one of those big to be answered questions, partially because it's terribly difficult to really be able to pull it out of the soil and know that you're getting it in these areas.
Well, the location geographically that you should cite it are southwestern soils, which tend to have a higher pH. So there are other soil quantities which tend to have a similar type of cycle, which are related to the pH, the higher soil pH. So I just wondered if there was any similar types of work that could looking at other type of models.
Yeah. And I think along those, what would be terribly interesting is to kind of do a comparison between where it's growing here in our soils and how that compares to Texas, and then further as you go down into the Americas of what it would look like. But I don't have an answer for that. Am I still?
You're good. You're
Okay.
good. One or two more questions and we'll move on.
Has public health been thinking about partnering with at least one local company or maybe one of the other companies that are looking at airborne pathogens, like almost like in real time, to look putting Cocci into that battery of tests that they did in terms of epidemiology?
Do we have anything from the county back there that might know off the top of their heads in terms of specifically looking about whether or not public health has been partnering with anybody to kind of pull out aerosols and looking at it? If you guys have an answer, I know that there are studies where they've looked at trying to pull it out of the air and to try to get this idea, because wouldn't it be awesome to say we're finding it in our air filters now? Do you?
We have with us
Yes.
Chris Tang and Mohammed Khan, both from the Arizona Department of Health Services, and also Ryan McCotter. Do you want to make any comments about the air sampling work that's been going on for a few years?
Yeah, so we try to collect samples, air samples.
Hold on, we're running you the mic.
The air. So we did collect samples, air samples, and unfortunately, the species is so tiny. Cocci is so tiny.
Did that get caught?
Actually, it turns out that if you do the math in terms of how many breaths, this is sort of
Dying on us.
almost easier to talk. That if you actually figure out how many times people breathe and how many liters you breathe in a breath and how many breaths you take in a minute and how many minutes there are in an hour, in a day, in a year, you end up with pretty astounding volumes of liters. And even what is called high throughput sampling, it's a challenging event. If the risk of inhaling the spore is 3% per year times the number of times, so 30 times what we do in a year is the number of liters you have to sample to find one spore. And it's actually a pretty challenging kind of thing. We'll have time later perhaps, but we'll certainly have questions in other time. Why don't we move on to our second speaker? That will be Dr. Kenneth Knox, who, as I said, is the... Oh, Shay? Yes. David, you have a comment? You're good.
There's a mic on the podium that you can turn on. That one should turn on with a little button, so you can turn this one off.
Oh, that'd be good. I'm so sorry about the technology. This thing, there is a little button here? Yeah, well, that's a light. And this is the one on the podium.
Oh.
Sorry about that. All right, so moving right along. Let me introduce Ken. Dr. Knox is Division Chief of Pulmonary Division, and his title is shown here. Pulmonary carcinomatosis, a lung doctor.
Is that all right if we just turn off the mic?
I think this one works. Is it?
Okay, mine's up like the...
Does this one work?
A little higher.
How about now?
No.
Just speak up.
That one.
This one's not true. The whistle's not because it's too bad.
The whining noise is a little annoying and distracting.
Okay.
How about now? Yours is off.
Yeah.
Very good. I was in a retreat last week, same room, same thing. Okay, well, John, thank you for asking me to speak today, and thank you, everyone. Sunday afternoon, with such a great turnout. I'm Ken Knox. I'm the Division Chief for Pulmonary Critical Care. I, too, am somewhat new to Arizona. I've been here 5 years. And one of the things that attracted me to Arizona, other than Dr. Galgiani and some of his colleagues, is endemic fungal diseases. And there are other endemic fungal diseases, histoplasmosis in the Midwest, blastomycosis also in the Midwest, and coccidioidomycosis here in the Southwest, often discussed in the same vein, but they're very different, as I've experienced here in Arizona. I'm just going to go through a few patients. I thought that would complement sort of some of the other talks that we have today. And quite frankly, from my perspective, it's the most interesting to talk about the patients that we see, and it's probably more interesting to you to hear what other people are dealing with when they come down with valley fever. I'll use the terms valley fever, coccidioidomycosis, and Cocci all interchangeably. There are some small differences which we may talk about just a little bit as we go along. So the first patient is a 55-year-old male, 55-year-old female. This is sort of how we would discuss. I was teaching the fellows or other students, we would go through a case just sort of in this format. So bear with me if the format's not 100% what you're familiar with. But it's a 55-year-old female who had a few days of cough and fever, and she basically just felt very crummy. She was a hiker. It was very difficult for her to do her hiking, and that was distressing to her. And let me know if you identify with this at all. It took her over a week to get into clinic. I'm not going to tell you how long, over a week to get into the clinic. But she was feeling better by the time she was able to see us in clinic. And when we examined her, her lungs were clear. And of course, when we don't know exactly what's going on, we blame viruses. Probably a viral infection. It was getting better. She had blood work at that time because we were concerned enough living in the endemic area to test for valley fever, and it was positive. The blood work that we do is called serology, for those of you who don't know, and it's essentially the body making antibodies to the coccidioides, so we test for those antibodies. And it was positive. We followed her along, and she got better without treatment. It's a relatively simple case, but I think it resonates that some people do very well with valley fever. And this slide hopefully shows that. If you look at this, approximately 60% of patients have no symptoms whatsoever. And we won't even know if they've had valley fever. It won't be, unless they come to the hospital or to medical attention for some other reason, that we actually know whether or not they've had valley fever. Sometimes we'll see residual findings on x-rays and CAT scans that suggest that valley fever, they were exposed and infected in the past. But what our patient shows us is that even though about 30% of patients who get exposed to valley fever or coccidioides, they get a pneumonia. Most of them resolve with or without treatment. But a couple of them worsen, and I'll show you a patient who did worsen. And then some have these sequelae or residual scars in their lung that tell us that they've been exposed in the past. As Dr. Galgiani mentioned, about 5% get what I call bad disease, disseminated. Sometimes they die from this disease. And then about 5% have the classic valley fever, which essentially is coccidioidomycosis with a rash and arthritis. So what symptoms do I see in my clinic as a lung doctor? Well, we have symptoms that come on very quickly: cough, fever, shortness of breath, pain when you take big breaths, that's called pleurisy or pleuritic chest pain. Those are things that we see often acutely or within days of exposure, if indeed there's a pneumonia present. Then we have chronic symptoms such as night sweats, fatigue, some rashes, some headaches, and weight loss. That can happen if you have sort of a subacute or chronic infection that lingers. We see that quite often as well. So that's patient one, a relatively straightforward case of someone who got better on their own. Case number two, or patient number two, is a 22-year-old male who went to the emergency room. Had 3 weeks of fatigue, and 22-year-old males are fairly stoic, so it took him 3 weeks to get to the physician, and of course used the emergency room. That's a political statement, not beyond the scope of this talk. But 3 weeks of fatigue, now with work.